He's had a number of years of experience with the Huntington Center in Chicago, and he joined us maybe 1 or 2 years ago to the UW, and in this past year has really become integrated into the center. And he does have a clinic at the UW, and so and he has seen a number of our patients, and that's always something that we can discuss if anyone's interested in your next visit or with your own docs. So with that, I will turn it over to Dr. Schrift. Thank you again for coming.
Thank you for the introduction, and thank you for inviting me to do this. Let me share my screen, and then we can get started. Can everyone see this?
Yes.
Okay, let me just move this away. All right, so this is the original paper by George Huntington on his disease, Huntington's disease. So George Huntington was in a family of general practitioners in Long Island. And actually his grandfather started the practice. And it was actually his grandfather who first, can everyone hear me, by the way?
Yes.
Okay, yeah. So actually it was his grandfather who first recognized people that we call today having Huntington's disease. And so he graduated Columbia University Medical School and gave his first paper after his graduation in New York. And then this paper that he gave was in Ohio. Let me move next one. So what he described in that paper was that the disease had a hereditary nature, ran in families, it didn't seem to skip generations, had a typical onset in adult life, unfortunately had a grave and unrelenting disability. He also noted that it was associated with chorea and with dementia, and led also frequently to inappropriate and uninhibited behaviors. He noted then, and it's still a common problem now, is suicide, frequent suicides in people. He said it was the illness that tended to insanity and suicide that ran in families. It lacked a response to treatment, and it led to early death. His original description holds up today. What I plan to talk about today are the cognitive behavioral complications of Huntington's disease, including the cognitive deficits that occur in people with this illness, and also the slew of neuropsychiatric problems that occur in people with Huntington's. Apathy, which is an all too common problem, irritability, depression, impulse control problems, psychosis, delirium, sexual disorders, and sleep problems. And then give an overview of treatment of people with Huntington's disease. So in North America, approximately 30,000 individuals have this illness, and an additional 150,000 individuals are at risk for developing it. Again, it runs in families, it's autosomal dominant. If you had a mother or father with the illness, you have a 50% risk to get it yourself. It tends to occur more commonly among individuals of European descent, but you could see it in any ethnic population. It has a prevalence around 10 to 15 per 100,000. And the incidence of Huntington's disease is approximately 4.7 to 6.9 new cases per million per year in the Western population. The median age of onset is around 40 years. It's rare, but does occur in individuals younger than 20 with the early onset Huntington's, or the Westfall variant it's called, or in individuals over age 65. And it affects men and women equally. It's a disorder of networks in the brain and particular circuits. And one of the critical areas of the brain that begins to degenerate in people with Huntington's disease is the striatum, particularly the caudate and putamen. And this is a critical structure for everyday behaviors. And again, one of the critical structures is the caudate. And if you look at MRIs of people with Huntington's disease, they look fairly normal, particularly early on. But if you look at this region here where the caudate nucleus is, it gets progressively atrophied. It sort of withers over time, particularly when someone becomes symptomatic. So these circuit problems lead to, again, common everyday behavioral disturbances. So one of them is loss of cognitive speed. There's an impaired ability to organize information. It's shown in a decline in attention, concentration, mental flexibility. Often people with Huntington's disease become sort of inflexible in terms of their thought processes. They often get stuck on certain topics and perseverate on those topics. They often have executive function impairment with the deficits in the ability to synthesize information in order to produce alternative solutions for problems. It often affects visual spatial functioning, planning deficits are also present, and affects one's ability to initiate behaviors, and often people become apathetic. And I'll talk about these things in more detail as we move on. Family members will complain that the patient with Huntington's disease won't do anything. However, once started on a task, often they follow through. They often perseverate, as I mentioned earlier. They often become fixated on thoughts and behaviors to the detriment of other activities they could be exploring. And impulsivity is an issue. Stealing, gambling, inappropriate sexual activities, irritability, poor anger control, all these things are related to impairment in these networks, these circuits that involve the striatum, the caudate nucleus, and the globus pallidus, and the putamen. Irritability is an issue. Temper outbursts, often the outcome of a loss of impulse control. Often confusion could lead to a temper outburst. Feeling overwhelmed can do that as well. People with Huntington's are often challenged by the inability to perform everyday routines, often losing the abilities imperceptibly over time. And outbursts can be violent at times. This is a common scenario that the patient quickly forgets about the incident while leaving the family members upset and shaken. And you come back to the patient with Huntington's disease 10, 15 minutes later and they act as if nothing happened. So in other dementias like Alzheimer's disease, where things like what's called implicit memory, or the ability to repeat well-practiced routines, are preserved, people with Huntington's disease often lose implicit memory. Things that involve implicit memory is like riding a bike, playing an instrument, driving a car. These things progressively deteriorate over time. And eventually the ability even to chew and swallow without choking is lost. And so explicit memory is what's affected in Alzheimer's disease, but implicit memory is impaired in people with Huntington's disease. Perceptions are also altered in people with Huntington's disease. So one key area that becomes impaired is perception of emotion. So Huntington's disease patients lose the ability to recognize emotion on others' faces. They can remember and identify the emotion, but their lack of recognition often leads to difficulties in social relationships. There's also impaired recognition of disgust. Things that would disgust anyone, even just mentioning it, would cause bad feelings in most people. People with Huntington's disease often don't recognize disgust, and things that would again cause people to become nauseous, or people to feel horrible if they even think about these things. People with Huntington's disease seem to be indifferent to it. Time is also impaired in terms of perception, particularly the correlation of one's internal clock with objective time. Persons may be late now, even though their whole life they've been punctual. Spatial and smell perceptions often become weakened. And lastly, illness awareness becomes impaired. People with Huntington's disease often lose a sense that something's wrong with them, which is not necessarily a psychological denial. It's what's called a nosognosia, or organic denial. It's not a willful rejection of facts, but it's the outcome of this disruption of a loop in the brain that is in part responsible for self-monitoring, for monitoring ourselves. And it becomes impaired in people with Huntington's disease. It's not unique to Huntington's, though. It's common in other dementias like Alzheimer's disease. Like often people with Alzheimer's disease forget that they don't remember. They are not aware that they have memory problems. Similar kind of thing could occur in Huntington's disease as well. The neuropsychiatric features of Huntington's disease are not as consistent as the motor or cognitive features, but they can cause substantial disability, be prominent early in the course of the disease, and even occur as initial features. So there's a sort of a rough rule of thirds. A third of patients with Huntington's disease present with a movement disorder like chorea. A third present with a cognitive disorder. They have problems with executive function and forgetfulness and impaired attention and concentration. And a third present with neuropsychiatric features. And that's what we're going to talk about now. The majority of Huntington's disease mutation carriers experience some psychopathology during their lifetime. Varies from irritability to psychosis, but the prevalence of particular symptoms varies widely, and it's really dependent on the different populations that are studied at different stages of the illness and the use of different assessment methods. So this wide variation in the rate and type of psychopathology that occurs during the lifetime of someone with Huntington's disease. The commonest is a personality change. This could be subtle, but then becomes aggressive. And there's been studies on this. One way to look at the personality factors that change over time is to do what's called factor analysis. And studies suggest three main factors. One is an affective anxiety factor. So mood regulation, anxiety regulation becomes an issue and gets integrated into their new personality change. Having problems with executive function and social cognition, as I mentioned earlier, trouble recognizing emotion in other people, that factors into their personality change. And a psychosis factor, although this factor tends to be small in these studies, but this is also part of this impaired social cognition factor. They often perceive social situations incorrectly, and then often act on those misperceived social situations. Having anxiety and affective disorder, mood disorders are common. It has a lifetime prevalence around 20% for anxiety disorders and about 20 to 56% for mood disorders. We'll talk about this more, but suicidal ideation is common, as is suicide. And many patients have an idea of suicide in a way as an insurance policy against inevitable deterioration. And we'll talk about that more. A large study that was done several years ago was called the Registry Study. It consisted of 1,993 Huntington's disease mutation carriers from 15 European countries. And these individuals were rated on a commonly used scale, the behavioral section of the Unified Huntington's Disease Rating Scale. And it looked at 5 neuropsychiatric features: depression, irritability and aggression, obsessive compulsive behaviors, apathy, and psychosis. And you could see on this graph that this is apathy. Apathy was present at all stages of Huntington's disease, but it progressively worsened over time. Almost everyone in the 4th or 5th stage has significant apathy, but apathy could even occur in people before they have the abnormal movements. Other things that are common: obsessive compulsive behaviors, irritability and aggression, and depression. Psychosis, having hallucinations, delusions, are much less consistent. Depression is very common, and some depressive symptoms are reported up to 50% of patients at some point during the course of their illness. The major depression that occurs in Huntington's disease is clinically similar to depression that occurs in individuals without the illness, and also management of that depression is similar to people without that illness, except for a few subtle differences. A major depressive syndrome has been part of the description of Huntington's disease since George Huntington first described it. In fact, the lifetime prevalence is high, again, around 30 to 40%, with a suicide rate 4 to 12 times that of the general population. Suicidality is quite common. As compared to, for example, Parkinson's disease patients. Parkinson's disease patients not uncommonly have suicidal ideas, but they rarely ever act on it. It's much more common in Huntington's disease than in Parkinson's disease. Severe cases may be accompanied by mood congruent delusions. An example of that would be having a false belief that you committed some horrible sin, some crime, and now the depression is focused on that horrible sin or crime that you believe that you committed, or having auditory hallucinations telling you a horrible, terrible person. Those are in severe cases of what's called psychotic depression or major depression with psychotic features. Looked at the symptom level, depressed mood is reported around 35 to 60% of persons with Huntington's disease. Depends on which assessment tool is used. Suicide rates in persons with Huntington's disease increase up to 12-fold to that of the general population, as I mentioned earlier. And there are really two critical periods in the course of illness that people are at most risk for suicide. The first is at the time of the diagnosis. And the second is when one begins to lose functional independence from their neurological dysfunction. Those are the two most common and two critical times where individuals with Huntington's disease become suicidal. It's important that patients are routinely screened for depression and its severity. It's also important to initiate treatment and communicate this issue to all the specialty providers for that individual. In one particular study, it discovered that the best approach to adequately screen for depression and Huntington's disease is to include questions about depression that relate to loss of interest, feelings of guilt, and suicidality as part of the assessment. The literature on treatment of depression in Huntington's disease is unfortunately scant in terms of pharmacologic or psychosocial or psychotherapeutic ways to treat it. But there's a lot of experience in treating the depression that occurs in Huntington's disease, and they often respond to any class of medications, and even to things that you may not think are still used, but are quite effective as electroconvulsive therapy. It's still one of the most effective treatments for depression that we have. But people with Huntington's disease may be more sensitive to adverse side effects of the treatment, such as developing a confusional state called delirium, or become agitated than otherwise healthy individuals. Again, apathy is common, often disabling, especially in the later stages of illness. As I mentioned, it tends to be progressive over time. And it's a prominent feature, even in people prior to having an abnormal movement, prior to having chorea. Mania could occur as well. So mania and bipolar syndromes have a lifetime prevalence around 5 to 10% in people who have Huntington's disease. It's higher than predicted by chance. And people with mania present with elevated or irritable mood, impulsiveness, increased activity. They have often abnormal hypersexuality. They have decreased need for sleep. They often have a grandiose self attitude, grandiose ideas about themselves. And severe cases may have delusions and hallucinations, often grandiose delusions. And as with major depression, mania could be the first indication of Huntington's disease. So Huntington's disease could begin with depression, it could begin with mania, it could begin with apathy, as well as anxiety and impulse control problems. However, it's important to be precise in diagnosing mania because personality changes such as disinhibition, irritability, facetiousness, which resembles mania, are common in the disease even without mania. So one needs a classic presentation to diagnose mania, and it has three essential elements. One is an elevated or irritable mood, another is grandiose or paranoid thought content, and having symptoms of overactivity, such as racing thoughts, pressured speech, where it's not the normal social rules of conversation where you talk and I and you speak, I speak, you speak. It's a more of a monologue. There's a decreased need for sleep, and again, hypersexuality is common as one of the common presentations of mania. The trait is frequently lacking in patients presenting primarily with what's called frontal disinhibition. So frontal disinhibition could look like mania, but it's not mania, and it often doesn't respond to the same kind of treatments. The mainstay of treatment for mood is a mood stabilizing agent. Usually an anticonvulsant is used. One of them is brand name is Depakote, divalproex sodium, or an antipsychotic drug, or what's also called neuroleptic. ECT could be used in refractory mania if that occurs. There's been a concern about the use of lithium because of poor response and possible toxicity. So people with Huntington's disease are certainly more susceptible to dehydration and delirium, and which may make them at risk when they take lithium, but responses have been limited in the past because of imprecise diagnosis. Lithium should be at least considered in cases with classic presentations of mania, and it can be used, and I've used it in patients with who have mania in the context of Huntington's disease, and patients could do quite well as long as it's monitored appropriately. Having psychotic mood states and psychosis, it's less common, as I mentioned earlier, though clinically important, and having more severe problems such as delusional depression or schizophrenia-like psychoses. But again, they do occur. There seems to be a familial aggregation. It runs in certain families, the psychosis. So not everyone with Huntington's disease develops a psychosis. It seems to run in particular families. We don't know what the genetic and environmental influences are for that. There's been some research in that area, but we still don't know what the determinants are of psychosis and Huntington's disease. Having a psychotic mood state or a schizophrenia-like illness might require an acute management, which includes inpatient psychiatric hospitalization and treatment. Having obsessive compulsive behaviors and disorder is another controversial issue in Huntington's disease. So having repetitive behaviors and speech, being inflexible, being perseverative, like getting stuck on a topic and repeating it over and over and over again, preoccupation with idiosyncratic topics are very common in Huntington's disease. But these behaviors may just be another aspect of the spectrum of what's termed frontal symptoms that make up the executive dysfunction disorder that occur in people with Huntington's disease. It's called preservative behaviors. Get rid of that.
Michael,
You're on
you're
mute.
Can you hear me now?
Yeah.
Okay, I'm sorry. Okay. Yeah. The prevalence of obsessive compulsive behaviors range from anywhere from 5 to 52%, whereas preservative behaviors occur in a much higher percentage of patients, 75% of individuals. So that have these frontal behaviors. Individuals with Huntington's disease, before they get a movement disorder, pre-manifest Huntington's disease, report more obsessive compulsive behaviors when compared to gene negative controls. However, individuals with manifest or with chorea associated with Huntington's disease report a higher rate of obsessive compulsive behaviors compared to those with pre-manifest Huntington's disease. Both having obsessive compulsive behaviors and perceptive behaviors associated with the duration and the severity of the illness, and they tend to decrease in the most advanced stage of the disease. It causes significant distress and impairment in functioning, and perceptive behaviors occur without the individual's full awareness or insight into their occurrence. So, again, they repeat things, they get stuck on certain topics, and the person is typically not fully aware of that issue and have little insight into the occurrence of those behaviors. Delirium is common in Huntington's disease and may result from volume depletion, poor nutrition, medical complications, metabolic disturbance such as the urinary tract infection, pneumonia, having medication side effects, having a subdural hematoma from having an unwitnessed fall and head injuries are common and a dangerous cause of delirium in people with Huntington's disease. There's a rule of thumb, though, that one needs to keep in mind, that nothing changes rapidly in people with Huntington's disease. So a sudden change in behavior or decline in cognitive ability should prompt an evaluation for delirium. Definitive treatments for delirium is to discover and correct the cause of that delirium. The use of low-dose antipsychotic or neuroleptic drugs are probably the safest pharmacologic treatment for short-term management of agitation in the context of delirium. Those drugs in and of itself don't help delirium, but it helps with the agitation associated with delirium. But again, discovering what the cause is and treating it is the mainstay of treatment. Sexual problems also occur in people with Huntington's disease. The most common sexual disorders include hypoactive sexual desire. They seem not to be interested in it. It's often part of their apathy. Inhibited orgasm as well, been reported in 63 to 56% of men and 75 to 42% of women. On the other end of the spectrum are sexual aberrations such as sexual assault, promiscuity, incest, indecent exposure, voyeurism. They've been described in Huntington's disease for decades, for 100 years. It's no doubt fueled by the disinhibition that occurs, the perseveration, as I mentioned earlier, impaired judgment, which characterize the disorder together with the impaired social cognition, as I mentioned earlier as well. There's no systematic studies of the management of inappropriate sexual behaviors in Huntington's disease. In very severe cases, anti-androgenic drugs that are used are Lupron, a drug that's often used in people with prostate cancer. It could lower testosterone levels and may be appropriate for people with severe cases of inappropriate sexual behavior. Sleep disorders are common, very common. Approximately 90% of individuals report sleep problems, including insomnia, difficulty in falling asleep, frequent nocturnal awakenings, excessive daytime sleepiness. It's quite common. Available evidence indicates that some sleep disorders are found early in the disease, even during the pre-manifest stage. These disorders are associated with comorbid psychiatric disorders, particularly mood and anxiety disorders, often affect sleep. Involuntary movements and increased activity also contribute to sleep difficulties. Many drugs that are used to improve the core symptoms of Huntington's disease may also contribute to sleep disturbances, including amantadine, clonazepam, diazepam, levodopa, olanzapine, quetiapine. There's a whole slew of medications that could sometimes help, sometimes hurt sleep functioning. When patients with Huntington's disease have insomnia, it's often for a wide variety of reasons, including depression, lack of daytime stimulation. There's also often a deterioration in their sleep-wake cycle. They're sleeping all day and up all night, and involuntary movements affect their sleep. Although the movements tend to fade during sleep, most movement disorders get better while you sleep. It may represent an obstacle to falling asleep or to going back to sleep after a nighttime awakening. A formal sleep study sometimes could be useful for confirming the type of sleep disorder that the person has. If career is interfering with sleep, bedtime use of an antipsychotic drug, a dopamine receptor blocker, or other drugs to suppress movements may help solve that problem. Agents such as sedating antidepressants, low-dose antipsychotic drugs, neuroleptics may be used judiciously to help sleep. Often, however, keeping the person awake during the day and active during the day, such as enrolling them in a day program, is one of the most powerful interventions for sleep disturbances in people with Huntington's disease. Valium kind of drugs called benzodiazepines or other sedative hypnotics are almost always not helpful in people with Huntington's disease. Apathetic patients with Huntington's disease often sleep excessively and spend an inordinate amount of time in bed. If you can get them out of bed and active during the day, that often helps their sleep at night. However, it may be acceptable to the patient and the family if it's understood as a feature of their illness that they want to just sit around all day. In cases where harm could result in the person not coming to meals or practicing good hygiene, judicious use of stimulants at times may be appropriate, but has to be used judiciously because there's potential of worsening the abnormal movements. So in general, psychiatric symptoms are probably the most amenable to medication therapy, pharmacotherapy. Of the motor symptoms, career is the most readily responsive. Cognitive symptoms and dementia unfortunately are the least responsive to psychopharmacology or pharmacotherapy. And unfortunately, there's a lack of clinical trials for psychiatric treatments in Huntington's disease. Most experts agree that depression in Huntington's disease responds to antidepressants. Most commonly, the selective serotonin reuptake inhibitors are usually tried first, but all classes could be used, but we do it in a sort of sequential way. Obsessive compulsive behaviors, anxiety and irritability may also respond to serotonin reuptake inhibitors, Prozac-like drugs. Mood stabilizers, as I mentioned before, like Depakote, valproate, carbamazepine, lithium may help with emotional lability and impulsivity. A drug called Buspiro may help with anxiety. Antipsychotic drugs, typical and atypical, atypical meaning the newer ones, may help with psychosis, delusions, agitation, but doses need to be maintained at a minimum to reduce side effects. And apathy may at times benefit from a trial of bupropion. Wellbutrin is one of the brands of bupropion, although it's often quite difficult to treat apathy with medications. There's also a slew of non-medication therapies that need to be utilized and probably are underutilized in people with Huntington's disease. So behavioral symptoms such as apathy and cognitive problems such as executive dysfunction can be helped through structured daily schedules, cueing the individual, having regular routines. All those things seem to help people with Huntington's disease. Having daytime respite care may provide a social outlet for the patient and also relieve caregiver burden. Caregiver burden is tremendous in the families of people with Huntington's disease. Family members of all ages struggle with interpersonal, financial, and social stresses of this illness, and the value of social work services as well as individual family counseling can really help families who are struggling with individuals who have Huntington's disease. Even in advanced Huntington's disease, this is important to remember. It must be assumed that the patient's recognition and comprehension are preserved. Having severe dysarthria, problems speaking, having rigidity, having what's called bradykinesia, slow in movements, they're often what's called bradyphrenic, slow in mentation, can make patients appear more cognitively impaired than they really are, leading to frustration and a loss of dignity. It's important that doctors who interact with people with Huntington's disease and family members should avoid talking over the patient. The effectiveness of many non-pharmacologic interventions are often limited by the patient's cognitive and behavioral status. As with many aspects of Huntington's disease, the burden of maximizing benefits from supportive interventions is unfortunately placed on caregivers. So unfortunately, current treatment is limited to symptomatic pharmacotherapy for behavioral disturbances and chorea and other supportive care. The major goal of current research is to identify disease-modifying therapies. Unfortunately, at this point, we don't yet have them. They're in the research phase, and hopefully within our lifetimes, these treatments will become available. Having an improved understanding of the genetic and molecular pathogenesis may lead to newer treatments with the greatest chances of success. So hopefully my presentation made you aware of the cognitive behavioral complications of Huntington's disease, the cognitive issues, the neuropsychiatric problems, and a treatment overview. And I'm at the point of questions.
Wonderful. Thank you, Dr. Schrift. That was an
Sure.
excellent review and discussion of all of many of the challenges that our families and patients face. So if people have questions, please enter them into the chat, and then I will read them out, if that sounds okay. And to get started, we did have a few questions already, so I'm just going to ask you about them. You talked about how often perception can be altered and people can perceive certain social cues and interactions inaccurately, and that can drive bad behavior or unhelpful behavior. And then the more extreme of that is when people start to get delusions and paranoia, and that can be sometimes dangerous, but certainly very uncomfortable and distressing. So when someone comes to the office and they have such delusional behaviors, what do you start with, or what do you do, especially when maybe they're not responsive to the first type of medicine you give them?
Yeah, so it really depends on what context those psychotic features like delusions occur in. So psychosis is sort of like fever. You could see it in a whole slew of different problems. So the first thing is to figure out why the person's psychotic. Is it part of a psychotic depression? Is it part of a schizophrenia-like illness? Is it a delusional disorder? Is it part of delirium? Probably the most common cause of psychosis in the world is delirium. Having hallucinations and delusions are common in delirium. So it's important to figure out what the cause of it is. If it is a primary psychiatric disorder, like a schizophrenia-like illness, then antipsychotic drugs would be the way to go. If it's part of a psychotic depression, what's called major depression with psychotic features, often a combination of antidepressants and antipsychotic drugs are used. Actually, the most effective treatment for psychotic depression is electroconvulsive therapy. Most patients won't want that as a first-line treatment. If I ever had that, by the way, I would want electroconvulsive therapy, but it is the most effective treatment. It works in over 90–95% of patients. Very few treatments in all of medicine are that effective, but usually you start with antipsychotic medication, antidepressant medication in someone with major depression with psychotic features.
Okay, great. And actually, since you brought up electroconvulsive therapy, can you speak a little bit more to it for treatment of depression or psychosis and in Huntington's?
Yeah, so it's rarely used as a first-line treatment. It can be in people with on death's doorsteps in terms of not eating, not moving, being catatonic. And it's again one of the most effective treatments. Let me describe what's done and how it's performed. So it's not like the movies that you've seen, like One Flew Over the Cuckoo's Nest, where electroconvulsive therapy was shown as a punishment to Jack Nicholson in that movie. That's not how ECT is used. It's not a punishment. It's again a very effective treatment, and it's done under general anesthesia. So the person gets it in usually the recovery room of the operating room in the hospital, and they're put to sleep with a sedating anesthetic, and then their muscles are relaxed with a muscle relaxing agent, and the anesthesiologist breathes for them, helps them with their respirations, and they give them extra amount of oxygen, and we monitor their EKG, we monitor their brain waves, we monitor the amount of oxygen that's in their blood. And once the patient's fully asleep and fully relaxed, then we give stimulation to the patient's brain to induce a seizure. And it's not a seizure where you see your arms and legs flail back and forth. You don't really see anything except for changes in the EEG. And you need to have at least 25 seconds of a seizure for it to be effective. And usually people need a series of these treatments. Usually between 6 and 12 treatments causes a remission. It's rare that someone would get better with 1 or 2. You need usually between 6 and 12. And afterwards, patients may need to have what's called continuation or maintenance treatments to prevent a relapse. But again, it's a very effective treatment. There are side effects, just like with any treatments. Side effects, most common one that's most talked about is memory impairment. But the memory impairment is actually transient. It's not a permanent memory problem. And what often gets confused about the memory issues with electroconvulsive therapy is a phenomenon called state-dependent memory. So if you were psychotically depressed for the last year, with or without Huntington's disease, you were psychotically depressed for the last year and got better on your own, no ECT, you would hardly remember what happened to you over the last year. It's a very common thing. Same thing in manic episodes. If you ask someone who had a manic episode who is now normal, you remember what you did when you were manic? They would hardly remember. And so that memory loss is often confused with the memory loss from ECT. So certainly anyone who's under general anesthesia is not going to remember what happened to them during general anesthesia. And also anyone who's had a seizure, you may not remember an hour before the seizure and a couple hours after the seizure. And often the series of, when you have ECT, you may only remember bits and pieces during the course of that treatment. But studies show that people who've had ECT by 6 weeks, their memory functions are as good as age-matched normals. There's no permanent memory problems with ECT.
Interesting.
Contrary to popular opinion. Actually, also areas of the brain that are responsible for memory, like the hippocampus, the entorhinal region, have increased volume with ECT. It's the opposite of what people think, that it causes brain damage. It doesn't do that.
Interesting. Okay.
Could you follow the comments with saying something about TMS magnetic stimulation?
Yeah, so TMS is approved by the FDA for major depression. I'm not aware it's approved for major depression in Huntington's disease, although it's been used. And although it's similar to electroconvulsive therapy, it's not as effective or powerful as ECT. It's if you look at the clinical trials with transcranial magnetic stimulation. So how that works is that you put a magnet over certain parts of the brain, particularly what's called the dorsolateral prefrontal cortex, usually on the left, and you can give certain frequency of the magnetic field will change the activity under the magnet. And studies show that it's as good as a trial of a third or a fourth antidepressant. It's not as effective as ECT, and the idea is different. So with ECT, the magic ingredient is the seizure, is the convulsion. With transcranial magnetic stimulation, it's an activation of a circuit. So it has a different mechanism of action. So again, with electroconvulsive therapy, it's the convulsion. So years before we used electroconvulsive therapy, there were convulsive agents that people used to induce seizures that had the same effect, probably had less cognitive side effects. They were injected intravenously. One of them was called metrazole. And there was another technique called fluorothil inhalant that induced seizures. And it probably had much less cognitive side effects than electroconvulsive therapy. The cognitive side effects with electroconvulsive therapy is due to the electrical current. It's not the seizure itself.
Interesting. And are there side effects with the transcranial magnetic stimulation?
Yeah, sometimes headache. That's the most common one. Headache is. Occasionally, patients can have a seizure with it,
Okay.
but headache's probably the most common.
Okay.
Or pain sometimes at the stimulation site.
Okay. So we have a question here. What symptoms or conditions initiate a referral for a neuropsychiatric evaluation?
Yeah, so in Huntington's disease, I see it maybe differently than possibly other doctors. It's mostly a neuropsychiatric disorder. The movement disorder is minor compared to the neuropsychiatric problems. Patients rarely ever come in saying, I have these abnormal movements. Be often even unaware of the movements. It's their neuropsychiatric problems that get them attention. So often they seek help initially from a psychiatrist, for example, or a therapist. And then someone realizes that they're at risk for Huntington's disease or they have abnormal movements, and they get referred to appropriate specialists to evaluate them further. So, but common things would be anxiety, depression, psychotic features. Having psychosis usually immediately prompts someone to go see a psychiatrist.
Right.
So anyone with those symptoms, I think, should be seeing a psychiatrist who is knowledgeable about Huntington's disease to be able to help them with those kinds of problems. Because again, the neuropsychiatric features are actually the most modifiable part of the illness.
Right. Okay, that's helpful. So, and then what are your strategies, or what do you do with really aggressive behavior that could include violence, even violence within the home, violence towards spouses,
Yeah.
that degree of aggression.
So you could divide aggression into two types. One is called instrumental aggression. Another is called impulsive aggression. And impulsive, they respond to different treatments. So impulsive aggression often is part of just a general impulse control problem that the patient has, and often things, and you wouldn't think about using this, but they are effective. They actually are effective right away. Are serotonin reuptake inhibitors. They work right away for impulsive aggression. There's a whole slew of studies of serotonergic functioning in the central nervous system, having low levels of serotonergic signaling in the brain and having impulsive aggression. And when you treat them with serotonin reuptake inhibitors, it often works right away. You don't have to wait for antidepressant effect, like for 4 to 6 weeks. There's certain disorders that respond right away to serotonin reuptake inhibitors. One of them is pseudobulbar affect, having pathological laughing and crying. The day you put them on a Prozac-like drug is the day that goes away. It responds right away. Another one is premenstrual dysphoric disorder in women who become irritable and have mood problems during their menstrual cycle. Studies show that you can give the drug, the serotonin reuptake inhibitor, in the just the week prior to their menses, rather than every day, and it has the same effect. It has an acute effect. You don't have to wait for an antidepressant effect. And for impulsive aggression and anger attacks, it works right away. So I usually use that as a first-line medication. If that doesn't work, then I often go to, depends how severe it is, I might start someone on an antipsychotic drug and neuroleptic medication. But anti-epileptics also work quite well. So like I mentioned earlier, Depakote or divalproex sodium, carbamazepine can be helpful. Lithium could be helpful in some patients.
How about the other type of aggression?
Oh, instrumental aggression. Yeah. So that is, it's much more difficult to treat because it's a planned out act. And that's much more associated with antisocial personality disorder. Again, it's quite difficult to treat. They often get treatment by way of criminal justice system and not come to medical help. The most common one that occurs in Huntington's disease is impulsive aggression, though. That's the most common. There are some pharmacologic studies in people with instrumental aggression. So lithium could be helpful, possibly antipsychotic drugs, but there's not any good studies on the treatment of instrumental aggression. I wish there were. I mean, unfortunately, prisons are filled with people with antisocial, psychopathic personality disorders, and we don't have a treatment for that.
Right. Right. And you mentioned apathy.
Yeah.
I imagine that is also hard to treat, or how do you approach it when it comes
So again, your environmental changes, enrolling that person into a structured program, having routines for them, so 8 in the morning, that's when we have breakfast. We expect you to be at breakfast and plan out their day. That often helps. They need that planning because they've lost their ability to make those kinds of plans. So they need their family's help to set their agenda for the day.
And so again, families, oh, sorry, go ahead.
Yeah, so enrolling them into a day program, setting up routines, you take a walk at 9 o'clock in the morning after breakfast, you do the same thing every day. Often people with apathy respond to that.
Right.
In terms of pharmacotherapy, occasionally I use bupropion. Maybe it works, maybe it doesn't. Rarely does though. Stimulant medications, the same drugs that are used in kids with attention deficit disorder, like the Ritalin kind of drugs could help, but you have to watch out for that because they can promote psychosis and abnormal movements. So you have to use it very judiciously and start at an extremely low dose and raise the dosage slowly, but it can be helpful.
So for family members, when they're looking at their family member, is there clues that they can look for to help them understand depression versus apathy and someone who's
Yeah, so this is a common confusion that I can't tell you how many times someone was referred to me for depression, and that it's actually apathy. It's called pseudo depression. So it's common in people who have damage to their dorsolateral prefrontal cortex. So you can see it in people with who have traumatic brain injuries, people who've had strokes in that region, people who have multiple sclerosis that affects that part of the brain, have brain tumors in those regions of the brain. It's a common thing. It's called, again, pseudo depression. And but people with apathy don't have the psychological features of depression. They don't have feelings of hopelessness, worthlessness, guilt, suicidal ideas. It's not part of apathy. They're just avolitional and don't have goals and things that they want to do like they did in the past, but they don't have the psychological symptoms. So what helps differentiate depression from apathy is having the psychological symptoms of depression, feelings of hopelessness, worthlessness, guilt, suicidal ideas. So if someone has that, then antidepressants would be the treatment if they had those psychological symptoms. Antidepressants don't work great in people with apathy. Again, bupropion is more of like a stimulant kind of drug than an antidepressant, but antidepressants don't work well in people with apathy.
so it's more behavioral,
Behavioral and sometimes
environmental.
stimulants.
Right.
There are two. Do we have time, Sumi? There are two things I wanted to
Yes.
have you discuss. The first is how you deal with the patient and the family who is beginning to say, my life is not worth living. I'm very unhappy with having this disease. I saw what happened to my parent who died with it. I don't want that to happen to me. I think I want to kill myself.
Yeah.
How do you make an approach to that kind of patient? When are there times when the decision is they have to be admitted for inpatient treatment? How do you deal with that kind of situation?
Yeah. So if someone is an imminent threat to themselves, then they need to be, it's due to the depression or suicidality, then they need to be hospitalized, hopefully voluntarily, but at times involuntarily. And sometimes you have to get even involuntary treatment for their depression. This happens every day in most hospitals in the United States, that patients are involuntarily hospitalized. The more metaphysical issue that you bring up is, you have an illness that, that you've seen other family members suffer with, and why would I want to live to get to that point? That's not easy to deal with, as you know. And one way that I tend to deal with that is try to reframe the issue. I don't know what's going to happen to me later today or tomorrow. I could leave my house today and I could get hit by a truck. I can't worry about that though. I can't deal with what's going to go on in the future. I can only deal with what goes on now, and I have to try to get through today. And one could focus on the future and how bad it could be, but one could focus on today and getting through today and do whatever you have to do to get through today. None of us can predict the future. And so whenever I interact with people with those kinds of issues, I try to reframe, that we all have a terminal illness called life. It's not unique to them. And so, you may have a label for this terminal illness that you have, but we all have illnesses that we're unaware of. We probably have at least 5-6 bad genes that may cause us colon cancer or strokes or dementia or other kinds of things that we're unaware of. But I can't worry about that on a constant basis. All I could worry about is getting through today. But again, if someone is an immediate threat to themselves or others, they need to be hospitalized to protect themselves from suicide.
Right. Yeah, good. The other thing I wanted to just bring up, because we've heard this a number of times from our patients and our families, I was really struck and agree with your presentation saying that the behavioral and psychiatric aspects of the disease can occur early and even be the first manifestations of the disease.
Absolutely.
And we've had families struggle with getting that acknowledged in their management and treatment. The example being someone who has had a positive genetic test, so we know they carry the mutation for Huntington's, and they develop either severe cognitive problems where they lose their job because they can't perform it anymore, or they become seriously psychiatric disturbed, maybe psychotic even. And they go to frequently a neurologist who says, I can't, they have no movement disorder. I can't make this diagnosis without chorea. I can't make the diagnosis without a movement disorder. And then they can't get their Social Security benefits because the doctor won't make the diagnosis. Social Security says you have to have the diagnosis in order to collect Social Security benefits. So I really think there needs to be an effort for the medical profession to recognize that the disease can begin with the behavioral and psychiatric aspects. And if you've got somebody who you know has the positive genetic test, you can say that they have the disease even though they don't have chorea. Would you agree with?
Oh, absolutely. And this issue I've dealt with in the past. I was an expert witness in a case of a woman who didn't have chorea, and a well-known Huntington's disease expert in Chicago said she didn't have Huntington's disease, even though she had the gene. And so, luckily, the side that I helped with that patient won, but this is it's a common issue. But it's changed in Alzheimer's disease, right? Because now we have biomarkers that we can get through CSF that we could diagnose with good certainty that someone has Alzheimer's disease. So you can have Alzheimer's disease with no symptoms, with subjective cognitive impairment, with mild cognitive impairment, and dementia. All those people have Alzheimer's disease. They all have Alzheimer's disease. Just they haven't yet developed their dementia unless they have impaired activities of daily living. So I think the same thing should hold in Huntington's disease, that if you have the gene, you have the illness, and we don't know when it begins. There's some studies recently in mouse studies that 13 weeks of gestation, there's changes in the brain of due to the mutant Huntington protein. This illness begins on day one. It's not something that begins when you first develop the abnormal movements. And if we wait for abnormal movements to begin and only treat people at that point, we've wasted decades of that person's life and not trying to intervene earlier. And that the studies that are going to help people with disease-modifying agents have to intervene decades before the person develops any abnormal movements. It's already probably too late in terms of neurodegeneration after they've already developed movements. So yeah, I agree that and there's now tons of studies to show that in terms of functional brain imaging, structural brain imaging, neuropsychological functioning, it changes again decades before you develop chorea or what's so-called manifest Huntington's disease.
We have to get the movement disorder specialist to agree with that.
Right. I agree.
This might, this is not directly a question, but this had been brought up. And Dr. Bird, you may have some familiarity with this project Change, which is intended to reframe the diagnosis of Huntington's to include psychiatric and cognitive changes, even if they occur before movement.
Right, yes. Actually, the HDSA, the National HDSA has a work group right now that's working on early diagnosis of the disease. And this is one of the issues that they're directly addressing.
Terrific.
That's great. That's great.
Yep.
Well, another question that had come in, and we've seen this often because we know that people will try medicines and they have to try different ones, et cetera. But there are a number of people that have been looking into genetic testing for compatibility with psychiatric medicines. Can you talk about your experience with that or your opinions about that?
Yeah, so for most of my career, I've worked at academic medical centers in academic neurology and psychiatry departments. None of us do that kind of testing for drug responsiveness. I wish we had a test that would predict someone responding to a particular medication. We don't have anything like that. I think it's a big waste of money. If you get a side effect of medication, you can get it whether you have an abnormal gene or not. And so all it tells you is about how you metabolize that drug. It doesn't say anything about whether you're going to respond to that drug or not. And so that's an important distinction, how you metabolize a drug and how you respond to a drug. So I don't recommend pharmacokinetic genetic testing at all. It's most insurance companies don't even cover it because they know the lack of validity,
right,
in terms of predicting response to a drug. It doesn't predict a response.
Okay.
Hopefully I answered your question.
That's helpful.
Okay.
That is very helpful. Are there other questions from the audience? I've been monopolizing the time. Great. Lisa.
I just wanted to address what Dr. Bird said about and the topic on progress change and trying to discuss with the early diagnosis with cognitive versus chorea. And just a comment, just an experience, because that's definitely what I experienced with Scott, Scott, and he was adopted. So getting he didn't get diagnosed till the chorea, but I look back and, probably 5, 7, if not longer years before was definitely the behavior and the outburst part. In the beginning, talking about how the outbursts, they'll forget shortly after, that really struck a chord with me. So I just wanted to address that I'm glad that was brought up about the progress change aspect of it. So thank you.
Yeah, so an issue is that the psychiatric complications of Huntington's disease, when they begin before the movement disorder, are non-specific, right? So there's tons of people who develop depression, major depression, who don't have Huntington's disease, right? Or anxiety disorders or obsessive compulsive behaviors. And also I'm a psychiatrist, and I'm going to criticize my own field. In psychiatry, doctors tend to believe that it's a primary psychiatric disorder until proven otherwise, as opposed to the rest of medicine, where you can't say something is primary or idiosyncratic unless you ruled out all the other causes of those kinds of symptoms. And so it's rare for a patient with even a first-time psychosis to get a CAT scan or an MRI, or getting appropriate blood workup, or having a detailed neurologic exam. And so I certainly agree with you that people with having psychopathology, they need to have a differential diagnosis, and one of the causes of psychopathology could be Huntington's disease. The question is, when do you do testing? Certainly, I would do testing if their mother or father had known Huntington's disease or had abnormal movements and a psychiatric problem. I would probably do that. The question is, how universal is that? I mean, does everyone with major depression need HD testing? I don't think that would be cost effective. So we would need guidelines for that. But I do think if you have a family history of abnormal movements and a psychiatric problem, and began in more midlife, and now son or daughter of that person is presenting with psychopathology, that certainly needs to be entertained as one of the causes of their psychiatric problems.
course, in Lisa's case, the problem was that he was adopted.
Right.
So that changes the management, how they viewed him, because he had no family history
Right.
of Huntington's disease, which makes a very big difference.
Right. Right. It does. So it makes it more difficult to associate the two. Yeah.
Yeah.
Other questions for me?
Well, this has been extremely helpful.
Well, thank you. Thank you.
And it sounds like what we're talking about is sort of a spectrum of symptoms that can be independent or can happen all at the same time, and makes medication sort of complicated
It does. It does.
process.
Right. And the burden on families and caregivers is tremendous. And so we certainly need much more research into the treatment of neuropsychiatric problems in Huntington's disease, and also to try to understand the mechanisms of why people develop these problems as part of Huntington's disease. There's a lack of research in that area.
Mm-hmm. So are there people doing TMS here
In Seattle, yes. Yeah.
for psychiatric disease?
Right. And UW is developing a new neuropsychiatric hospital at where Northwest Hospital is.
Mhm.
And they're going to have a neuromodulation suite with both TMS and also ECT.
Terrific.
Yeah.
Okay, well, I'm sure if anyone has other questions that they come up with later on in the day, you can send them to me or send them to EJ, and we'll forward them on to Dr. Schrift, and
Great.
we can get those out to you. And
Sumi, could
Yeah.
EJ, could I ask, so I think this was recorded. Will there be a way for people to review it at their leisure later on?
yes, great question. And so our goal will be to get this posted onto our website, and then you can get a link from there and watch it. And I believe it turns into a YouTube video somehow. So we'll get on that.
I'm gonna be on YouTube. Wow.
I think it's like a private YouTube.
Okay.
I'm now speaking way beyond what I understand.
As long
but,
as I'm not on TikTok.
yeah, right.
Okay.
The Schrift dance. Yeah, so we will make it available. We'll get it on the website.
It was very valuable, and I think it'll be very valuable for people to review it in the future.
Yeah,
Thank you.
absolutely.
Thank you
We
very much.
touched on
Thank you.
we touched on so many topics, so it's very clear, helpful.
Great.
Okay,
Great.
thank you so much, Dr.
All right.
Schrift,
Thank you.
and we'll see you all
You-
later.
You guys have a
All right.
great weekend. Okay. Bye-bye.
All right.
Bye-bye.
Thank you.